Hello, everyone, and welcome today to the Medicaid Insights Colloquium, also known as the MIC. We're excited to have you all here with us today, and we have a special treat today, a session that's a little bit different than the ones that we've done before, but in a way that's really exciting. I'm Jamila Michener, and in addition to being one of the organizers and on the planning committee for Mike, I'm also a professor at Cornell. I'm co-director of the Center for Health Equity there and co-director of the Price Initiative, which stands for the Politics of Race, Immigration, Class, and Ethnicity. And I do some other things as well, but we're here today to talk Medicaid. Before we get into the substance of the discussion today, I want to take a moment to recognize the rest of the planning committee. And they've all done and continue to do work to make these events possible. Sarah Gordon is at Boston University at the School of Public Health there, and she's co-director of the BU Medicaid Policy Lab. It's hard to think of a better policy lab than a Medicaid policy lab. John McConnell is the director of the Center for Health Systems Effectiveness and Oregon Health and Science University in Portland. Yeah, sorry, and that's actually the hosting organization for this program. So we can thank that organization for us all being here today. And Will Shepero is assistant professor at Weill Medical College at Cornell, where I'm also at, but just not at Weill. And so together we are the planning committee. Today, we have a special discussion planned with members of the National Medicaid Medical Directors Network. That's a mouthful, MMDN for short, with the steering committee. Members of the steering committee are here with us today. So MMDN does important work to advance the health of Medicaid beneficiaries across the country by providing a nexus for senior clinical leaders in Medicaid across the US to discuss their most pressing needs and to share best practices. The MMDN conducts multi-state projects on pressing topics, builds on research and quality improvement efforts, hosts yearly convenings, and leverages the collective experiences of people in this space to support and advance both state and national work. As each of our four panelists introduces themselves, so they'll each introduce themselves, they're going to share some of their research needs for this year. And through our time together today, they're going to answer questions that you all offer and also provide context related to the policy applicability of their work. Throughout this discussion, I'll be serving as the moderator. And that means that I have the pleasure of introducing our first panelist. Please join me in welcoming Mohammed Dar.
Hello, everyone. Good afternoon or good morning, depending on where you're joining us from. My name is Mohammed Dar. Friends call me Modar. I am a senior medical director at MassHealth, Massachusetts Medicaid, the combined program for Medicaid and CHIP in the state of Massachusetts. I also have the pleasure of serving as the national chair for the MMDN this year. The Medicaid Medical Directors Network is a network that has been around for almost 2 decades and started as a voluntary body for folks who have a job like mine to just be able to talk to each other, share insights and challenges amongst each other. And it has blossomed over the years to be that plus so much more. This includes a cohort you see that encompasses most of the nation of Medicaid medical directors who share insights, share challenges, share strategies for how they serve the Medicaid population in their respective states. If for the states you see in blue marked left, I know a few of them are hiring for the role right now, but if you know anybody who'd be suited for that, please feel free to let me know. Always can be in touch with the Medicaid directors themselves in those states. The MMDN is a body that comes together for open microphone meetings to talk about issues of the month. It also has dedicated criteria of what we discuss, and we have a number of collaborations. The Medicaid Outcomes Distributed Research Network, Modern, Project Accelerate. These are multi-state initiatives where we've come together to share data on initiatives that matter to us directly. We've also been coming out more with a voice on what the challenges are across national Medicaid, such as our prospectus paper on the FDA Accelerated Approval Program. We've had other voices throughout these years, especially in the COVID pandemic. We were early out speaking to what the national bodies could do to support Medicaid's response to COVID-19. We've talked about logistical targeting and challenges for vaccination of the homebound populations in our states. And we've talked about how the Dobbs decision affects us in our states, regardless of politics, but speaking to the on-the-ground work that we all do to serve the Medicaid population. You'll hear from our colleagues today that there are a number of areas we're all focusing on. This is a list, not even itself exhaustive, of the many various areas where probably each speaker is working on something related to these issues in their Medicaid agency. We'll highlight a few per agency, but just wanted to give a sampling for the robustness of work that happens in this sort of role for each person who is serving in the network. Looking ahead, each of our members will present on their own Medicaid agency as well to give you a flavor and a sample for what they are doing in their realm of the world, and then we'll come together to speak as a group as well. So in a moment, I'll talk to you about Massachusetts Medicaid. For us, Massachusetts Medicaid, as I said, combined program for Medicaid and CHIP in the state of Massachusetts. Size-wise, in a state of about 7 million people, encompasses about 25 to 30% of Massachusetts residents in any given year. Around 70 to 80% of those members, less than 21, are getting their care through a managed care arrangement. We are not purely a managed care or a fee-for-service state. We actually run both programs as an insurer, but also a regulator of our managed care partners along the way. And naturally, for us, like most Medicaid agencies, we are a significant share of the state's budget. And therefore, we have the onus of being good stewards of the public dollar. A few of the pieces I'll talk to you about is we recently renegotiated our 1115 waiver with CMS. We are focusing on strengthening our accountable care initiatives and implementing a primary care subcapitation. We have exciting work on health equity, and I'll also speak to our behavioral health work. So in primary care, we have done accountable care over the last 5 years in Massachusetts, similar to models you've seen before, a overlying modification based on quality measurement and total medical expenditure, or total cost of care, TME, TCOC curves, to try to make the system more outcomes accountable rather than just paying for fee-for-service payments visit by visit. However, we were still dissatisfied with how far we'd come because a lot of the care on the ground still existed on a fundamental foundation, a chassis of fee-for-service. And we wanted to see how we could better augment the accountable care system. In a short order, what we're more interested in doing is moving from paying for visits to paying for panel. So how could we subcapitate the primary care portion of our payment for practices, and then also still keep them accountable to quality and total cost of care along the way? So we created that model. You see this slide speaks to what's called tiers of requirements. We knew that if we created that model, we needed to account for adjusting based on medical as well as social risk down to like zip code level, social determinants of health. But then how do we give credit to practices who have built more integration into their practices if we're paying for panel? So we set tiers. We have a tier 2, here you see a tier 3. In these tiers, we say if you meet a certain level of integration in the Massachusetts program, we will actually capitate you at a higher amount to capture that level of lift you're doing. So you see tier 3 practices have after hours access, they have requirements on LARC and opiate use disorder treatments. They may have pharmacist visits and group visits. This is what we hope will be a new chassis for our primary care programs. For health equity, we are significantly investing in trying to improve the health equity landscape here in Massachusetts. We are putting forth a 9-figure amount each year of our 5-year journey to, one, be able to support on-the-ground efforts that are already happening at our ACOs and our hospitals. 2, strengthen our data collection, race, ethnicity, language, sexual orientation, gender identification. These are things people don't have to disclose when they sign up for the Medicaid program. But if we are to measure, find inequities and address them, we need to get better at our data collection. So we will be investing in that. We will use that to define what are the data gaps as well as the inequity gaps along the way. And by the end of the 5-year journey, we want to put real money accountability, just like quality metric, onto our systems and our hospitals to close those gaps. On the world of behavioral health, not only for the Medicaid side of the shop, but for our state, Massachusetts has been implementing a behavioral health roadmap. This includes our behavioral health helpline, which more than just what you've heard for 988 at the federal level, speaking to crisis care. This speaks for a central point where anyone seeking care can go, regardless of what level of care they need. We're trying to simplify our administrative processes, strengthen our networks with further loan forgiveness and other programs, and train our workforce accordingly. Coming to the bottom of the slide, I spoke to how we're going to integrate more services into primary care at those higher tiers. And then we are setting up behavioral health centers and behavioral health urgent centers throughout our state on a regional basis, making sure that each region has one of these centers, working in concert with the helpline, working in concert with the other pieces to make sure that no matter where anyone enters, there is a system of behavioral health available to them. And those centers will have the ability to hand off to outpatient centers, as well as to go directly to inpatient psychiatric beds if need be. These are just a sampling of some of the things that Massachusetts is taking on. What I am looking forward to is what my state colleagues show next. It's my pleasure to introduce you to my colleague, Jana. Her patients lovingly call her Dr. B at TennCare.
Good afternoon, everyone. It's a pleasure to be here with you today. I serve as TennCare's Deputy Chief Medical Officer, and I'm also a board-certified OBGYN. And at TennCare, I lead strategic clinical initiatives and policy development. Recent areas of focus that I'll touch upon today are women's health, social determinants of health, and also our opioid strategy. And I also serve as a clinical subject matter expert, provide management and oversight of clinical operations and our managed care contractors. So if you've seen one Medicaid program, then you've seen one Medicaid program. So I'm really glad we're talking about our individual states today and giving you a preview on that before diving into the research discussion. This is a picture of Tennessee, and I've got 2 questions for you. Pop quiz. Tennessee is bordered by 8 states. So I wonder if you can think what those 8 states are. Second question, there's one other state in the United States that is bordered by 8 states. So see if you can guess what that one is. Real reason why I share this slide is because Tennessee is diverse. We have areas that are urban, and those are the lighter areas. I'm sorry, can we go back one slide? And the darker areas are shaded, and those are the more rural areas. And so when we think about equity, when we think about the care that individuals receive, we have to think about the context of that within Tennessee. Next slide, please. Tennessee is not an expansion state. That means TennCare is the combined Medicaid CHIP program in the traditional sense. We cover children, pregnant women, caretakers of minor children, and individuals who receive SSI payments, or those who need long-term services and supports. And then, of course, you must also meet the individual income and resource tests as well. So overall, we get about 300,000 to 400,000 new applications per year. Next slide. So we currently have around 1.7, almost 1.8 Tennesseans enrolled in TennCare, and that's out of a total state population of about 7 million. It's approximately a quarter of the state's population. We do provide coverage for pregnancy, prenatal, or antepartum, postpartum care for about 50% of the births that occur in the state, and we currently cover over 50% of the state's children. We are a 100% managed care state. All of our managed care health plans coordinate care for our TennCare members and maintain the network of providers, and we have carved out benefits with pharmacy as well as dental. Next slide. I want to touch on the history of TennCare because this is pertinent in many ways to the upcoming discussion, and that is the TennCare program has transformed considerably in the past couple of years. And in short, in the 1990s, there was a time where the program was unpredictable, unsustainable, We were plagued by enrollment caps, limitation to services. There was volatility in our healthcare plans, and through significant reform and restructuring, we're in a much better place today. But the mission is maintained to provide high quality, cost-effective care. And again, this plays into the research questions that we'll discuss as well. That drive for evidence-based policy decision-making is integrated into the fabric of TennCare today. So I want to touch on this because it's been in the news a lot recently. And so we recently had to, just in our normal timeline, renew our waiver. And we were asked, and actually legislation was adopted and enacted into law to create a waiver amendment that would be aligned with this block grant that CMS had proposed. So we finalized an agreement with CMS in 2021 and entered this new era of structure. Sorry, one slide back, please. And in this new era, we have a path to demonstrating successful fiscal management and actually get rewarded. So we have additional enhancements that are called shared savings. And these shared savings, this is a great diagram to be able to understand it. In essence, if we're able to demonstrate that we are maintaining fiscal accountability with key quality metrics, that are set based on the CMS core standard set, then we have available additional dollars that are called shared savings. And if we're unsuccessful at maintaining that performance on those key quality metrics, then there might be less shared savings that are available to us. But I share all this because today we don't like to put the cart before the horse. The fiscal responsibility, the concerns for being able to provide high quality, cost-effective care really drives the policies and initiatives that we put forward. And so when we're making decisions on what new programs or initiatives we want to put forth, we really have to ask ourselves the questions, how does this impact the state? Is this the right move for us? And there's a lot of noise in that space today. So this slide shows you, there's so much excitement around maternal health, and there are a lot of questions to be answered still. So many proposals of this is what can be done to improve the state of maternal health in both the country and individual states. But the reality is we don't have the research, the answers that we need to be able to say, this is what Tennessee needs, this is what Tennesseans need. And here are a couple examples of that. Doulas, community health workers, midwives, birthing centers, remote patient monitoring. We're just getting noise from everywhere. And as an OBGYN and as a public health professional, I want to make sure we're putting forth the key drivers to address the needs of the population. Why do we have high rates of preterm births? Why do we have high rates of low birth weight babies? We might be able to get to those answers through a lot more research and analysis that's occurring on the ground with maternal mortality reviews and infant mortality reviews, which are providing a wealth of information to us. But the flip side is if you do X intervention, it will impact that outcome. It will change that final health outcome that we're seeing for mom and baby. And that's where we really would need some more answers provided to us. So is it that a maternal health home was created in X state and they saw these results, or the natural experiment that we're seeing around the United States right now around doulas, what impact doulas can have on which population, when and where do they need to interface with the patient, and what manner? Is it in person? Is it telehealth? Is it prenatally? Is it postpartum? The who, what, when, where is a huge need in the space of academic research that I hope to drive home today. That's just me personally, because I'm a maternal health expert. I'm happy to hear more from Dr. Magni Hamso from Idaho.
Hi, thank you. Magni Hamso, I'm an internist and addiction doc, and I am the medical director for Idaho Medicaid, first full-time medical director here in almost a decade. In addition to working at Idaho Medicaid, I'm also a part-time staff physician at the Boise VA, and I'm on faculty with UW as a clinical associate professor. At heart, a primary care doc, though, and worked in FQHCs before I came to Medicaid. So Idaho Medicaid is a Can you go back one slide? Thank you. Idaho Medicaid is a rural and frontier state. We have only 9 urban counties. Most of our state is rural. A lot of our state is frontier. We have major workforce issue for physicians, doctors in training, also nurses and direct care workforce. We don't have an academic medical center, so we don't have the backing of a research center and some of the experts that my colleagues have. And we are recently a Medicaid expansion state. It became effective in 2020 through and was passed through a ballot initiative. So really the support of the people. We're largely fee for service. Only our duals, Medicaid, Medicare folks are in managed care. We also have a behavioral health managed care plan and a dental managed care plan, but a lot of our program is fee for service. You can see they have very, very small personnel costs, 0.47% of our budget. And we struggle for that reason. We struggle with data and really understanding what's going on with our population. And like Jana said, really knowing what to do here locally to improve health outcomes. You can see our enrollment, just under over 400,000 participants. That will probably go down a little bit at the end of the public health emergency. And you know, that's probably around 20% of our population. And for expenditures, you can see that there are certain populations that it makes sense are more expensive. For example, coordinated adults, that's 7.4% of the population, and that's over a quarter of expenditures. Those are our folks who are disabled and have a lot of especially home care needs or complex medical conditions. And you can see our expansion population up top is almost a third of our population, but lower in terms of expenditures, but getting a lot of attention right now because it is new and it's not a population that traditionally has been supported here in Idaho. I wanted to just point out spending by category of service, focusing on this first bar, which is prescribed drugs. And that is really a huge focus for Idaho and other states. You know, it's been all over the news, of course, that drug costs are increasing dramatically everywhere. And it's a huge issue for state Medicaid programs. Although our states have a lot of support from the federal government in covering costs, there is that state budget that often is limited and capped to some degree. And the bottom line is more spending in one area sometimes means less spending somewhere else. There's a lot of rules related to prescription drug coverage. There's a Medicaid drug rebate program. And as part of that, the federal government helps us obtain lower cost drugs by requiring a federal rebate from the manufacturers. But at the same time, we're required to cover that drug if it has an FDA approved indication, regardless of effectiveness. And that makes it complicated with some of these newer drugs that have had accelerated approvals. Can you go back one slide, please? We have some limited levers to control costs basically and utilization of lower effectiveness drugs. We can use therapeutic prior authorizations. We can have preferred drug lists and negotiate with manufacturers, supplemental rebates in exchange for sort of preferring one drug over another if they're considered equally effective. But the bottom line is there are limits here, and especially with some of these newer drugs that often cost over $1 million a year, there's a huge impact on that Medicaid program, especially small Medicaid programs. Next slide. This is a white paper that Modar also referenced earlier, but just thinking about the accelerated approvals program and, you know, how some of the newer drugs come to market really with very limited effectiveness data. In this paper, they call out some of the drugs for Duchenne muscular dystrophy, and that's something that we've been thinking a lot about here in Idaho too. Some of these drugs have been approved pretty much on safety data. and some surrogate markers, some of them for dystrophin, increase in dystrophin proteins, for example. But we don't know how to monitor these patients. We don't know what outcomes to look for. We don't truly know if they improve quality of life, function, life expectancy, et cetera. And yet, because they have a rebate and they have an FDA-approved indication, we're required as a state Medicaid agency to cover them. So it makes it really difficult and really can cripple budgets. And again, if there's more spending in one area, sometimes that means less spending somewhere else because states have to balance budgets. CMMI recently released 3 new models to look at some of these issues, and they do talk about accelerated approval. So it'll be exciting to see sort of what research and what we learn from that work. But obviously the problem is here right now. And I think this is something that all of our states are really struggling with. So I'm going to go ahead and pass the baton to Dr. Chris Chen from Washington, and I often email him with questions. Idaho often looks to Washington for support. Go ahead, Chris.
Thanks, Magni. It's nice to be neighbors. Hi, everyone. I'm Chris Chen. I'm also an internist, and I work as a medical director for Medicaid here at the Washington State Healthcare Authority. The Healthcare Authority wears a number of different hats. We're a Medicaid agency, we're a public purchaser, and combining those roles, we cover over 1/3 of the state of Washington, 800,000 on the commercial side and 2.2 million on the Medicaid side. We're also a behavioral health agency and a health IT agency. Obviously today, speaking mostly on behalf as a Medicaid agency, I have a map here. We have about 2.2 million folks enrolled in Medicaid as of May of last year, as I mentioned. And we do have a significant fee-for-service population. About 15% of our population is fee-for-service, including duals, AIAN individuals, other individuals who do not enroll in managed care. We cover about half the kids in the state. As well as a similar percentage of the births. Highlighting a few agency initiatives here, and some of you might be familiar with these too. So the Medicaid Transformation Project has been a significant priority for our agency over the last 6 years. Our initial waiver focused on transformation through the Accountable Communities of Health, which have convened communities in ways to reduce disparities. Sorry, if you could go to the last slide. So Foundational Community Supports was another program that was funded through the waiver that helps vulnerable adults find and maintain stable housing and employment, and actually showed some significant outcomes improvements in terms of ED utilization and hospitalizations. We're currently undergoing a waiver renewal process to expand coverage and access to care, ensuring people can get the care they need, as well as advancing whole person primary preventive and home and community-based care, and accelerating care delivery and payment innovation focused on health-related social needs. Value-based purchasing has been another priority for the agency, and since 2016, we've been on the road to link a majority of our payments to value as defined by HCP land categories 2C and above. And we largely achieved those. So our target, starting from a base of around 20% VBP in 2016, and the slides needs a little bit updating, but we're able to get up to 85% of VBP in 2021, which is a significant achievement. Other agency initiatives, health information technology is really emerging as a significant priority, and our agency had a role in issuing the Promoting Interoperability Funds as part of the High Tech Act. Some selected initiatives here. Integrated eligibility enrollment is really important in terms of reducing barriers to access for clients. Our goal is to get to a 20-minute application for services including WIC, TANF, Medicaid, SNAP within the next couple of years. And so I think that's a really important initiative to reduce access improve access to Medicaid, as well as some of these other kind of fundamental information technology initiatives that you see here. Next slide. Kind of speaking more at the MMDN level, I wanted to share some priorities that the network has related to health disparities and health equity, and highlighting a perspectives paper here that was published just last month that talks about our perspective detailing Medicaid's origins and relationship to equity, which can be somewhat complex. Given the complexity of the program, it can be used as both a tool to advance equity, previous slide. It can be used as a tool both to advance equity as well as to restrict access to care. Medicaid does have a really significant role in reducing disparities, and from the inception of the program, including mandatory benefits such as transportation to medical appointments, does have a really robust history in addressing social determinants. And I think a lot of the state agencies around the country, including some of those that you've seen here today, have been at the forefront of initiatives to reduce disparities, such as risk adjusting payments to include social determinants, covering health-related social needs services, et cetera. And the paper also goes into data and measurement and understanding disparities, and how do we strike that balance between collecting data in standardized ways, in ways that make clients feel like they can trust how the ways in which their data are being collected and measured, but also how do we take action? There are lots of reports available that document disparities in health outcomes. And so how do we kind of avoid the so-called analysis paralysis and really move to improving outcomes? Which leads me to the next slide on priorities for research evaluation. I would say that there really is a lot of work going on, as I mentioned, payment strategies to address health-related social needs, and would be wonderful to have more evidence on the effectiveness of these initiatives. Many of these initiatives, such as California CalAIM, Washington currently has a similar initiative to pay for health-related social needs under in lieu of services, such as medically tailored meals and medical respite. Many of them are based on the literature in terms of having demonstrated effectiveness, medical appropriateness, clinical effectiveness. But as we take these initiatives to scale, it would be really interesting to understand what's effective for whom. Value-added benefits is another flexibility available under managed care to address health-related social needs. Would be interesting to understand how that's utilized and where it can be effective. Payment strategies to reduce disparities is another area of research, including, as I mentioned, value-based payment models, social risk adjustment, as well as access for commercial versus Medicaid. And I think there has been some literature here, but we all know that commercial pays significantly more than Medicaid does. How does that impact things like unnecessary procedures, access to specialty care? And lots of great data resources available now with APCDs across the country that might be available for studying that, as well as impact of changes to eligibility and enrollment criteria. So those are just some of the priorities that I would share on behalf of the network, and I'll turn it back to the moderator here for further discussion.
All right, thank you. Thank you, Christopher. That was a lot in the most wonderful way. And I think as a researcher, all of the cylinders are firing, and lots of ideas are flowing, in part because, at least for myself and likely for the other researchers here, we want to make sure that we're producing research that's useful to folks like yourselves. So hearing about your work and what you're doing is especially exciting, and I think especially generative for our ideas. So that's really great. It's also great that we have questions from our audience, lots of inquiries here. And so I'm just gonna jump right in so that we can talk about some of the things that came up. So maybe I'll start with a broad question that any of you can answer, but maybe we'll go in reverse order and start with Mohammed or Modar. I have to get used to the shortened version. You know, and this broad question, again, anyone can chime in, but it's really a question that I think relates to something that researchers are always thinking about, which is, does anything that I'm doing make a difference? And so the question is, what are examples of research that has helped you or your program? And related to that, connected to that, what advice might you have for researchers in the audience about either how to develop research ideas that might be helpful, or how to think about the kinds of research that might be helpful, even outside of the specific topics, because you all actually gave a lot of pointers around specific topics. And I think we probably, you know, are going to have to think. It's nice that this is being recorded, because I kept thinking I want to go back and really watch and write down systematically all of the ideas that emerged. But just in a broader sense, what kind of advice for how researchers might approach their work in ways that would facilitate more rather than helpful work. And, you know, that question of examples, like how has research helped you, and can you think of any examples?
Sure. Research has been very much on our minds at MMDN. We recently had inside the clubhouse meeting, but with partner organizations. One is State University Partnership Learning Network, Suplin, who met with us to talk about randomized control trials or other quasi-trials in Medicaid implementations. It was a fun meeting. We had a Medicaid director show up. We had a journal editor show up. I think a lot of our groups are thinking about these. I'll pick one example out of a hat just to talk about like spectrum of research. Some states have or are thinking of expanding doulas in their Medicaid benefit. And I think all spectrums of the research are helpful. The research that says this could be beneficial for your population, or it's been done somewhere else. Another bit of research for the states who went out first was, what did they learn along the way? What was uptake? Because even little design components of how easy it is for a doula to build a Medicaid agency, or is the rate set at a rate that gets uptake, is helpful for the next state that comes along. And then on of the evaluative research that goes. So I don't think there's one particular way of doing the research. I think as long as you're asking a critical question that helps influence a decision for someone. One of the joys and pains of Medicaid is that there are 50+6 versions of us. So no matter where you are in the implementation timeline, likely someone is still thinking through things. Otherwise, I would say it's helping us know who our control group is along the way. We as state organizations, there's a politics apparatus that makes us not want to hold back something we think could help. So it's really hard in the middle of the COVID pandemic to say we're going to randomize homebound vaccinations for only half the population. That's not going to pass the governor's office. But how do we still compare if it worked and if it did good? I think that's some of the places where partnership and helping us think through how we proceed is helpful. I'll turn it over to my colleagues.
That's great. Does anyone else want to chime in?
This is Magni. I might just say, you know, Idaho Medicaid is a very tiny Medicaid program, and we are fee for service. We have very small administrative staff. And I think the more sort of almost like review articles to summarizing literature. I think a lot of our states work with MMDN. There's also the Medicaid Evidence-Based Decision Project that's also, which is part of the Center for Evidence-Based Policy, also OHSU affiliated, and it's sort of an annual membership, and they do a lot of this sort of gathering the evidence related to doulas, for example, because I, as like the only doctor within Idaho Medicaid, don't have the capacity to look into all of these issues with great detail, and our other staff can't either. So I think the research is really important, but also thinking about how to combine and summarize, whether it's through a systematic review or meta-analysis or some other way, is really helpful, because oftentimes there just isn't the ability to truly look into the details on a lot of these different topics, because we're pulled in so many different directions. And the research does matter, because, for example, whenever I want to add something to coverage here within Idaho, I have to have a cost effectiveness analysis and basically a budget ask to our legislature, right, to add something new. So that is also really helpful to sort of understand the return of investment for adding a new service.
Yeah, that's great. Anyone else, if they want to chime in on that question, can. Otherwise, I have others, but I just want to make sure you have a chance if you want to. All right. Yeah, and I mean, it's really helpful hearing those specifics about how research can be useful to you and the reasons why it can be useful to you. So maybe jumping in a little bit more kind of nitty-gritty questions here. One question is what is the role of financial incentives for addressing equity? And specifically, this questioner wanted to know whether MODAR or in Massachusetts or in any of the other states are using sort of incentive-based structures to try to address disparities, to reduce them, or to advance or encourage work towards equity. So I don't know if anyone has any immediate ideas about that, but thoughts about financial incentives and advancing equity.
Jamil, I can take. Oh, go ahead, Modar.
No. I already spoke. I'll go after you.
I was just going to say, Jamil, I think there are some really interesting examples across the country on using incentives to narrow disparities. And I'll just highlight some of our colleagues from Michigan have shared the VBP mechanism that they've used to narrow disparities. And so specifically, a withhold is a mechanism for a state Medicaid agency to withhold funds from managed care organizations, but then return it to them on the basis of performance on quality measures. And in Michigan, there was an initiative to stratify quality measures by race, ethnicity, and also to assess them on an area level basis rather than managed care. We've heard that it has been effective in narrowing disparities. I will just say this is definitely an area I think that needs further research and evaluation. With the kind of upshot being that money isn't always the answer. And I'll just use kind of a contemporary example in COVID vaccine. Medicare was reimbursing $40 per shot administration. And Medicaid rates for reimbursement, you can imagine, are across the board lower in reimbursement rates. And so especially facilitated by the enhanced federal match for vaccine administration, most Medicaid programs increase their reimbursement accordingly to match Medicare. Well, we've seen from data across the country that the disparities still existed in COVID vaccine rates. And at least here in Washington, we've had about 20 to 30 percentage point, absolute percentage point differences versus the general population. So I think there certainly is a role in financial incentives to reduce disparities. Exactly when and where that works, I think there's lots of outstanding questions still.
Yeah, that's great perspective. Oh, Modar, did you want to add to that?
I will echo what Chris is saying. To pick an analog from quality measurement, there are times a measure works if you put money behind it. There are times when a measure is topped out. There are times a measure may be measuring a process, but not an outcome. And we're more interested in wanting outcomes, but processes are easier to measure. I think we're going to have similar challenges with trying to measure inequities and close gaps. As you saw in my slide for Massachusetts, we believe there's a role to be played here and make folks pursue the incentives that are on the table. But many of these are moving targets and concepts, even down to how we categorize, for instance, SOGI data, sexual orientation, gender identification. Those constructs are moving quickly, and there's probably a different definition a year ago from how OMB at the federal level categorized those versus CMS versus state A versus state B. I think we're all on a journey to try to get towards a place where we're speaking the same language and concepts along the way.
Yeah.
I want to add one thing to that, because you mentioned speaking the same language. The question was asked about financial incentives, but in the examples that we heard spoken about, there were financial incentives that were driven towards the MCO. There were also financial incentives driven towards the provider. There are also ways to do that focus and target on the member. So that's just want to flip it back to the research question. We do need more research in that area to understand when it's appropriate to create a financial incentive around X that would actually change the outcome.
Yeah, that's a really great set of distinctions and observation there. It's quite thought provoking. So we have a couple of questions that are about Medicaid managed care and just a kind of acknowledgement of the fact that Medicaid managed care has a large role in Medicaid generally, although that varies across states, and a growing role. And so the questions really orient around what are the implications for this, right? Are there kind of tools embedded within a managed care structure that can help us to sort of vary policies in ways that address concerns that we might have, or help us to gain more leverage on understanding how to improve Medicaid? Or are there sort of advantages or disadvantages of Medicaid managed care that are relevant to keep in mind when we're thinking about the kind of footprint of managed care in Medicaid writ large? So just general questions about Medicaid managed care and its implications in relation to some of these larger challenges and concerns moving forward that we've been talking about thus far today.
I'll give the Massachusetts point of view. As mentioned, we're a hybrid. We actually have managed care, but we still have our own product as well. We've been comfortable in this space because it holds both sides accountable, at least from our point of view. It makes sure that our baseline product, where we are the core insurer, we're keeping up with changes in the marketplace or changes in coverage. And then for the managed care side, we're also able to compare and make sure that they are still offering a value for our membership. In the promise of managed care, it's supposed to be that they have to do a minimum of what the state says, and they could do more. So they have some more nimbleness to experiment. So we've been comfortable with that. There's a push-pull in either direction. COVID's probably a good example of like, where was the money in April 2020 when nobody was going to the hospital except those sickest? And if you were in a state that did everything on hand, that was in your pocket, ready to deploy for what you need. Versus if you're in a managed care state, it was with the managed care organizations. And then you had a different policy problem to solve of how do you still get that for the landscape, which is having disparate, unanticipated effects. So it does raise a heterogeneous set of challenges depending on where you are.
And this is Magni. I might just add in Idaho, because we are largely fee for service, right? We have behavioral health and managed care, dental and managed care, and then our duals are in managed care. But largely it is a fee for service program. And actually during the COVID pandemic, even though that money didn't go in a per member per month to a managed care organization, we were actually really limited because there was no way for us to really reach our Medicaid participants, right? We have a very, very sort of small general funds that are really just tied to services that are provided to patients. And so there is more flexibility to do outreach and engage participants in a unique way, do sort of programming that we can't do because we are stuck in fee for service, paying for a service or procedure or medication provided to a patient. And obviously that differs by state too, and what the state budget looks like and what the resources of that program are. But in some ways here in Idaho Medicaid, although it's nice in many ways to be fee for service and not have that sort of middleman in a way, there are some limitations as well.
Yeah, those are really helpful thoughts. And just to hear you all emphasizing how different things are in different states is personally nice for me because much of my research focuses on that aspect of Medicaid. So we're coming down the home stretch here, but I thought maybe we could get in one more question, and this one perhaps might be specifically useful to some of the people who are on the call and might be interested in it. The question points out that a lot of Medicaid policies are implemented in ways at the state level that don't make strong evaluation possible. As state Medicaid, and the question is, are state Medicaid agencies interested in partnering with research teams to co-design implementation strategies with an eye towards having higher quality evaluation work and research that helps us to understand the effects of policies that are implemented? So I'd love to hear what you all think about this, and specifically about how to go about establishing these kinds of partnerships. I know that I have an ongoing partnership with some folks in Kentucky, and it really was established in a pretty coincidental way, just a series of people who know people who know people, and you end up working together. And I think for researchers that maybe want to think about possibilities for working with states to maximize how much information they can have about the policies that they're implementing, it's not always clear what the best inroads to that kind of work are, even though it seems like it could be mutually beneficial.
Yeah, I'll start us off on this one, just because we have a couple unique relationships in the state of Tennessee. So certainly there's publicly available data that's reported, CDC is a good example of that. But we also have partnerships with specific entities within the state of Tennessee who are data partners. And while they may not be involved on the front end as we're developing a new program or initiative, they have at their fingertips all the data that we also have, so that they can assist and perform those analyses and do those evaluations. So that's a unique cooperative agreement that we have with a couple entities in the state, which is mutually beneficial. So that's what I would advise if, again, outside of looking at that publicly available data.
Go ahead.
Yeah, and Jamil, I'll just add, I think absolutely Medicaid agencies are interested in partnering, and I think there's lots of really robust forums, including the one that Modar mentioned, the State University Partnership and Learning Network. The limits tend to just be in capacity and bandwidth. And if we kind of take that list of topics that Modar displayed of 30 topics times 50 states times 100 academic medical centers, it's kind of a dizzying, but I think there are definitely opportunities where researchers have specific interests, specific capacity, and for partnership and in building those relationships. And I know here in Washington, we're working on an academic learning collaborative to make things a little bit easier. A lot of these things can get stuck in data share agreements or contracting, and how do we kind of facilitate those kinds of arrangements? And so the supplement has been really helpful to navigate those dynamics. And I will also just say TMSIS data is getting better and better every year. And Jana mentioned the different available data sets. And I think that this offers another opportunity to really bring research and evaluation to scale where there is, as Magni mentioned, every state Medicaid program is different. And so it does take some knowledge in understanding the data and interpreting it, what those program differences are and how that might be reflected in the analyses.
Yeah, that's great. And
I would encourage researchers to start the conversations early. I think many of folk in a Medicaid agency also come from a research background or an academic background. So there's a lot of interest and always a voice in the ear. Is what we're doing working? We want to know too. There's going to be somebody in a state structure, no matter where you are, who's going to say, well, if you do this, is it going to be on the front page of the paper, big article splash that Medicaid did something and it was a complete failure? The way to get through that is to develop mutual trust, develop from the outset what are the goals that the study is going to evaluate, and what are the primary outcomes, the secondary outcomes. I think if that's established earlier on, everyone knows what they're paddling towards, and they know what outputs will come of the work to mutual benefit. I think if it's a late pitch, then it's harder to necessarily build that foundation of both planning and trust along the way.
Yeah, that's helpful. And we have to, wrap up now, although it's hard to do that because there are so many questions remaining in the chat and questions that we haven't had a chance to get to. I think it speaks to the value of these kinds of conversations between folks who are in the positions that you all are in and researchers who are thinking about how to do research that is maximally impactful. I personally wanted to ask you all your approach to and how you incorporate, if at all, qualitative research into your work. especially because of my own emphasis on drawing directly on the experiences and the voices of Medicaid beneficiaries through systematic qualitative research. I think often in these conversations, it can be implicit that we're talking about quantitative research. And so I was going to ask you all about that. We have questions in the chat about price transparency and prescription drugs and so on and so forth. So there is much that will remain undiscussed, but I think the discussion that we did have and the ability to hear from you all was quite illuminating. And I think it speaks to the need to continue to organize venues like this for these different kinds of folks who are in the Medicaid world to come together and think about how we can combine our efforts and our work productively. So I'm going to stop there. I'm going to thank you all, offer you the most hearty thanks for being here today, for offering us your insights, for drawing on your experiences and your knowledge to help us all to think more deeply about what kind of research we can do and how we can do research better. So thank you.